Hi, thanks for joining us. My name is Jack Rychik, and I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. Welcome to Pediatric and Congenital Heart Talks, a series of lecture presentations and discussions on interesting and important topics in our field of pediatric and congenital heart care. In this series, we will share insights on a variety of topics, offer new perspectives on some basic principles, introduce novel concepts and innovations, as well as identify what needs to come next to solve challenging problems in our field. Our objectives are to provide education on a variety of topics, but also perhaps to stimulate some provocative thought on your part. We'd love to hear from you and to get your questions and thoughts on these discussions. You can contact us at this email address, chophearttalks@email.chop.edu. Okay, let's go ahead and get started. When I meet folks for the first time, they ask what I do. I tell them I'm a pediatric cardiologist. Sometimes folks sort of look at that and kind of scratch their heads and say, oh, I didn't realize kids get heart attacks all that often, that you need to have pediatric cardiologists. And I say, no. There are structural and congenital abnormalities that of the heart that I focus in on, and that's what I care for. But the fact of the matter is that coronary disease, coronary abnormalities, are potentially prevalent in the pediatric and young adult population. In fact, perhaps they may be one of the leading causes of unexpected sudden death, in particular in athletes. I'm sure many listeners as well have had the experience here of having a child with a murmur and then referring that child with a murmur for an echocardiogram, and then the coincidental finding that, oh, a coronary insertion site or course looks different or abnormal in some manner. What we're going to hear the next couple of minutes is a fantastic talk on answers to those particular questions. Coronary anomalies, definition, diagnosis, and dilemmas. And nobody better to do that than Julie Brothers. Julie is a world expert in coronary artery anomalies. She is an associate professor at the University of Pennsylvania, Perelman School of Medicine. And we've been a colleague for many, many years. She trained here at CHOP. And over the next few minutes, we're going to learn everything we need to know. We're going to clarify everything we need to know about coronary anomalies in the young. Julie.
Thank you so much, Jack, for that wonderful introduction. So I just wanted to let everyone know I have no disclosures. I always like to start out my talks with a couple of patient presentations. So these are kind of examples of who we may see in our coronary anomaly clinic. The first one is a 14-year-old male athlete who presented with multiple episodes of near syncope immediately after cross-country races. These did not occur with his usual, just regular runs with his teammates, but really was after the races. He developed nausea, pallor, and hypotension. This was documented at one point. He did seek medical attention due to his symptoms, and he really was hypotensive. They gave him some fluids, and then they sent him off. It took him quite a while to recover from the symptoms, up to an hour. He didn't just bounce back and go finish the race. This was something where he really felt significantly poor for a while. But he otherwise denied chest pain, shortness of breath, palpitations, or true syncope. The review of systems was otherwise negative, and the family history was non-contributory. So given that constellation of symptoms, certainly we got an EKG that was normal and an echocardiogram was obtained. And it showed this, and as you can see here, there's a suggestion, it just kind of froze there, but a suggestion of a coronary anomaly. There, it keeps going. You can kind of see it right there. So after that, we did get a cardiac MRI, and you can see very nicely the right coronary artery arising from the left sinus of Valsalva in close proximity to the origin of the left coronary artery, which arises normally. The next patient, patient B, is an 8-year-old male who was referred to the cardiology clinic after experiencing dizziness while playing basketball, followed by syncope a few weeks later just after running. He denied chest pain or palpitations. Dad noted that after the single pole episode, he was rigid for about 1 to 2 minutes, then lethargic for 1.5 hours. He was taken to an outside hospital, and there was a concern for seizure given the amount of time it took for him to recover. But the EEG was normal. Family history was non-contributory, and their pediatrician sent them to the cardiology clinic, where an EKG was normal, performed an exercise stress test, which was normal. He did not have symptoms, but the echocardiogram showed this. If you focus up here, you get the sense that that left coronary is coming from the right side, with a hint that that runs in the wall of the aorta or an intramural course. So of course we did get a cardiac MRI, excuse me, to confirm the diagnosis. And this goes a little bit fast. So if you kind of focus up here, you see when it plays one more time, focus right there. You see that left coronary artery really hugging the wall of the aorta, which is one of the really good ways to tell if you think it's interarterial and really intramural. So let's define coronary anomalies. I think this is what's really important. And first we want to say, what's normal and what's abnormal. So I think a good rule of thumb is to say, anything that's found in more than 1% of the general population should be considered a normal variant. Thankfully, most coronary abnormalities of number, origin, and course are of intellectual interest only. But I think what we, as healthcare providers and cardiologists, it's really incumbent upon us to recognize which variant or variants may result in myocardial ischemia, arrhythmia, and possible sudden cardiac arrest or sudden death. So there are different kinds of coronary anomalies. There are anomalies of origin, which include L-kappa and R-kappa, the single coronary artery, and the anomalous origin from the wrong aortic sinus, which is what we are going to focus on during this talk. But there's also anomalies, of course, which includes myocardial bridging and myocardial duplication, as well as anomalies of termination, including coronary artery fistula and extracardiac termination. I really like this illustration showing the different coronary anomaly subtypes. So in blue here, these are, and I want to point out these are all anomalous left coronary subtypes. This is a pre-pulmonic course of the anomalous left coronary, and those are really felt to be benign. There have been no cases of sudden death or ischemia with this type of anomaly. There's also in purple here this retrocardiac. I've never seen one of these. I think they are exceedingly rare, but I believe it's felt to be benign as well. In green, you see this retroaortic course. This used to be felt to be a benign course, but there have been a few case reports of sudden arrest or sudden cardiac death, and we'll get into this later, but I think it's really, if this origin is slit-like and has an intramural course, I think this could be considered a higher risk anomaly. And then the two subtypes I think are of most clinical importance, and you're going to see the most, are going to be this type in the orange, which is, they call the subpulmonic. Other people might know it as the intraconal or intraseptal anomalous left coronary artery that runs below the pulmonary valve in the conal septum and then emerges on the epicardial surface. The other clinically important subtype is this interarterial, commonly intramural left, anomalous left, and anomalous right. This next echo I just want to show, because I showed the previous two were the interarterial course. This is the echo of a 12-year-old male who had a screening echo due to his father with a bicuspid aortic valve. He was completely asymptomatic, and it was just done as a screening echo. And sorry, that went by a little bit fast, but as you hopefully were able to see, let me see if I can replay that for you. Good. So that the left coronary artery seems to come from the right sinus of Valsalva, but seems to go away from the aorta, does not hug the aortic wall, as the other one did from the interarterial, with the interarterial course. And this is a cardiac MRI, and this is actually, sorry, it runs a little bit slow, but you can really see here the difference between the interarterial and the intraseptal course. So this is like almost a single right coronary artery. It almost has this kind of common stump coming from the right coronary artery. You can see here, they bifurcate into the right coronary, and there's the left coursing underneath the pulmonary valve. So quite a different look from that interarterial course. The prevalence of anomalous coronary artery ranges from 0.1 to 0.7% of the general population, and that really is the interarterial course. All coronary anomalies actually are over 1% of the population, but really focusing on that interarterial course, it's anywhere from 0.1 to 0.7% of the population, depending on which modality you use to diagnose the AOCA. The anomalous right coronary artery, or AORCA, is about 3 to 6 times more prevalent than the anomalous left coronary artery, but the risk of sudden death is much greater with anomalous left than anomalous right, and most commonly during or just after exercise. So I think the big question is, why are patients at increased risk for sudden cardiac death? And it's something that we still are, struggling with figuring out. We certainly think that there are anatomic features that lead to physiologic consequences. And these include things like the slit-like ostium, which I'll show you an image of shortly, the interarterial, but really that intramural course, meaning that course in the wall of the aorta. And because of that, there's often this proximal narrowing with an acute angle takeoff. So this is an image of a virtual angioscopy MRI. And what it shows you here is it allows the observer to view the data set. So you're standing as if you're inside the aorta. And you can view the aortic sinuses and the ostia and the sinotubular junction. From this, you can really see the elliptical slit-like opening of the right coronary artery compared to the round ostium of the left coronary artery. So this image shows kind of why we think that there are these certain mechanisms as to why arrhythmias and ischemia that are primarily arise with exercise that have been postulated. Certainly we think that the increased cardiac output during exercise may lead to valve-like obstruction of this slit-like orifice here due to vessel expansion. Remember also that exercise leads to increased pressure and volume during systole, which may cause lateral compression of this intramural course. Strenuous physical exercise also results in shortened diastolic filling time and tachycardia, which could lead to ischemia and arrhythmia. There have also been some postulates that coronary spasm and flow restriction through the relatively non-compliant pericommisural area may also be a contributing factor. So we looked at using the Congenital Heart Surgeons Society registry features that were associated with myocardial ischemia. We had enrolled 560 patients, and there were 236 patients who had negative ischemia tests, and 49 here with evidence of ischemia, including 18 of them who presented with a sudden cardiac event. The other 275 asymptomatic patients had not undergone provocative ischemia testing, so we did exclude them from primary analysis. And what we found that patients with ischemia versus those without ischemia were more likely to have anomalous left coronary artery, and those with anomalous left coronary artery who had ischemia were more likely to have an intramural course, a high orifice, and a slit-like orifice, and those with anomalous right coronary artery who had ischemia compared to those who did not had a longer intramural course. Among patients with ischemia, the occurrence of sudden cardiac events was not shown to have any associated anatomic features. So now I want to get into, what is the risk of sudden cardiac death? I think trying to understand that risk when we are talking to patients, when we are making a decision about surgery versus no surgery, I think we need to understand the natural history risk, the risk of death from that certain anatomic abnormality compared to the risk of undergoing surgery is very important. That being said, there is uncertainty in what I'm going to talk about, and I'm going to be making some assumptions when I do kind of come up with what we think the risk would be. So looking at 2 fairly recent studies that evaluated sudden cardiac death in populations under age 35 in the United States, found 4 deaths due to AOCA in a combined 34 million patient years. One study had 2 deaths noted that both were associated with vigorous activity and both were anomalous left coronary artery. The other 2 deaths from the other study, they did not know the anatomic subtype or if it was with exercise or not. I think with this we can say the risk of sudden death from AOCA in the general population of children and young adults is really too low to measure. But there's a different risk, I think, for those participating in competitive sports. And those of you who take care of these patients, it seems to be a large number of them are competitive athletes. So I think this is where our challenge remains. So getting started on how to figure out, what the risk is. We're going to go with the prevalence of anomalous right coronary artery of 0.23% and anomalous left coronary artery of 0.03%. This is taken from many different ways of estimating prevalence from echo, cath, CT, and MRI. So let's think about the number of competitive athletes in the United States. Middle school, about 1.8 million, high school, about 3.5 million, and college, about 78,000, giving us about 5.5 million competitive athletes in that middle school to college age range. So now let's figure out how many athletes probably are out there with anomalous coronary artery. We're going to assume a prevalence of 0.26% from that previous article. A 6-to-1 ratio of anomalous right to anomalous left gives us about 12,000 anomalous rights, 2,000 anomalous lefts, for a total of around 14,000 athletes playing sports with anomalous coronary artery. Most of them probably don't know they have it. So how many sudden death events are there annually in the United States? Let's say there's an average of 65 in the internet era, but we're going to assume more. So let's assume there's 120 sudden death events per year because we know that the reporting is not perfect. 17% of those deaths are due to AOCA based on some studies by Barry Marin in the past. 85% of those deaths appear to occur between the ages of 12 to 22 years, which really encompasses that middle school to collegiate age range. And about a 4-to-1 ratio of deaths from anomalous left to anomalous right. So that gives us about 20 deaths per year from anomalous coronary artery. So deaths in the 12 to 22 age range, so about 17. Those from anomalous right are going to be about 3.5, you're not going to have 3.5, so around 3, and around 14 from anomalous left, which gives us an annual incidence per 100,000 of about 28. That's per year, per 100,000 from anomalous right, and 843, which is about 1% per year from anomalous left. And these are, I want to say as well, these are interarterial course. The general population incidence of sudden death is about 0.6 per 100,000. So putting that in perspective, the annual incidence of auto-related mortality for teenage males in the United States is about 20 to 25 per 100,000. So it's on that same range of death from anomalous right. So I guess something to think about is, would you let your son drive to baseball practice? I think the other thing to think is, for those with anomalous right coronary artery, the cumulative risk for a patient who participates in both middle school and high school sports is about 0.15%. And I think we have to ask ourselves, do we really believe our operative morbidity and/or mortality risk approaches this? And we're going to go over that in a minute. So what about the risk of surgery? Once again, very important to have this discussion and to understand this when we are thinking about how we're going to treat our patients. So certainly the surgical morbidity is there. Pericardial effusions are present in a decent number of patients with coronary anomalies. We're not exactly sure why, but it does seem to be something that's fairly prevalent. In the more midterm, we found some coronary osteostenosis and atresia, and in the short to midterm, aortic insufficiency has been reported, largely when that commissure has been taken down and resuspended. We actually did a study looking at the morbidity post-surgery, and this top line shows there was no mortality, but the morbidity in terms of symptoms and other events happening was pretty high. Patients who had chest pain before, a good chunk of them had chest pain after. It just didn't seem to make a difference. So I think we also have to say the long-term surgical morbidity is unclear. We've just not been doing this surgery long enough for us to know what happens to these patients when they're 40, 50, and 60 in terms of their coronary ostia. This was also published, which is really nice, looking at morbidity associated with operations, different operations for congenital heart disease. And you can see the anomalous coronary artery repair. There's a category score ranked from 1 to 5 with in-hospital risk of in-hospital death from procedure, and anomalous coronary repair is at 3. There's a morbidity score from 0.1 to 5, and it's a 1.6. Postoperative length of stay is about 13-ish days, and the major complication rate's about 10%. So certainly not without risk. And similarly was published about looking at mortality associated with congenital heart surgery. So the estimated mortality risk is about 2.5% from a coronary anomaly repair. So while the operative mortality is relatively low, I think it was somewhat surprising to me that rate. It's not as low as I think some of us may believe, but it certainly varies by center and experience, absolutely. But I want to also bring up that there are reports of postoperative deaths outside of the hospital after patients have been cleared. They've gone through their postoperative exercise tests and they've been cleared and have subsequently had sudden cardiac arrest or sudden death. Interestingly, these patients seem to be the ones who presented with sudden cardiac arrest in the first place. So the question is, does surgery decrease the sudden cardiac death risk? I think compared to the natural history, we just don't know. I think we don't know yet. We need to be careful not to confuse the relative safety of the operation with the efficacy. The incidence of sudden cardiac death in patients with anomalous right coronary artery who are not engaged in vigorous sports is exceedingly low. We will never have sufficient numbers to use in this population to assess postoperative efficacy. I think the focus needs to be on the postoperative population involved in competitive sports. No series has systematically evaluated this. It's challenging. We do have our Congenital Heart Surgeon Society, AOCA registry. We do have data, but it doesn't reflect all of the postoperative patients, but it is something for us to consider in the future. So talking about surgery, I wanted to go back to my first case, that young man who had significant symptoms with exertion, and his MRI actually I didn't show, but actually showed evidence of fibrosis and scars. So this young man had ischemic events in the past. So definitely he was a candidate, we felt, for surgery. And really nice here, you can see this right coronary artery with a pretty long intramural course. You can see this real slit-like ostium here after he was unroofed. Really nice image here. That coronary comes off, it looks nice and open, and on this. And you can see a really nice difference here. That ostium looks nice and round. So, what are we missing? A lot of things. We are still unable to adequately distinguish the higher risk anomalous coronary artery patient from the lower risk. I think notably in the asymptomatic anomalous right coronary artery, as well as we are finding more of these interarterial but not intramural anomalous left coronary artery. Are they the same risk? Some centers have been using dobutamine and other forms of stress MRI to help with risk stratification. So we're finding some subtle changes with dobutamine. But I think the challenge is, especially in these asymptomatic patients, if these findings truly correlate with clinical outcomes, does that really mean these patients are at increased risk and would have had a sudden cardiac event? I think we still don't know that, but it is certainly promising. We have limited knowledge regarding risk of future sudden cardiac arrest or sudden death in patients who present with this and undergo surgical repair. Like I alluded to earlier, we have case reports, both published and anecdotal, of patients who have died or experienced recurrent sudden arrest postoperatively after being cleared for sports. Because of that, most of us do not allow these patients to go back to competitive sports, at least in that first year. There have been some thoughts about placing an ICD in these patients, but technically if they were repaired, we do believe that they should be somewhat lower risk, but it is definitely something that we are looking into further about the best way to manage these patients. And we have lack of long-term follow-up just because we've not been doing the surgery for that long, about 15 years or so. The short and medium-term results are absolutely encouraging. Issues such as new aortic valve regurgitation and coronary osteostenosis and atresia will definitely need to be followed over time. I want to stress the importance that these patients need to be transitioned to an adult cardiologist or an adult congenital cardiologist, and they need to be followed as adults. These are not patients that, oh, you've had surgery, you're good to go. I think this is very important. We found with our registry, a lot of these patients are very hard to find, and they do not seem to be following up. So something to kind of have that discussion when your patients become college age. So I think, and I will say the caveat, until we know more, how would we evaluate and treat these patients? So you get the echo. We definitely recommend a confirmatory test, depending on your center, a cardiac MRI or CTA. If there's documented ischemia, then it's a no-brainer, we go to surgery. But if the patient's asymptomatic or the symptoms happen but without documented ischemia, we definitely want to get some provocative testing. So an exercise stress test with stress echo. We've kind of stopped using the nuclear medicine as much. And then a stress MRI. Many centers are using dobutamine. We use bicycle and are looking into starting dobutamine as well. If this is all normal and it's an intraseptal anomalous left coronary or an anomalous right coronary artery, patients are asymptomatic or the symptoms are not concerning for a cardiac origin, we are allowing them to compete in sports with counseling about there is a very small risk. We do recommend that an AED is present at sporting events, at practices. I have some families who ask about personal AEDs, and I think, it's not a bad idea, especially for certain athletes who do sports such as baseball or soccer that are going around to fields that are not likely to have AEDs. The one thing that I do say is make sure that if they're bringing it in their backpack or their bag, that someone else knows it's there so it can be used if needed. For an anomalous right, if they have symptoms that are concerning for ischemia, or an intra-arterial anomalous left coronary artery, we generally do recommend surgery. So for the rights, usually after 10. For the anomalous left, somewhere in that 5 to 10 year age range. Once they undergo surgery, we kind of redo the tests that we did before surgery. So we're talking a provocative test. We like a cardiac MRI as a post-operative around 3 to 6 months. And then I think a stress MRI is absolutely reasonable as well. And then if all of that's normal, we do allow them to go back to competitive sports with the caveat about patients who presented with sudden cardiac arrest. We do not let them go back for at least that first year post-operatively. So my final thoughts. There are many challenges that remain with risk stratification and subsequent management with AOCA, notably intra-arterial, intramural anomalous right coronary artery. For asymptomatic patients with anomalous right coronary artery with negative provocative tests, the risk of sudden death in the general population is too low to measure, and the natural history is one of very low risk, even in competitive athletes. We do not have proof that surgery alters the long-term risk in those patients who are asymptomatic. For asymptomatic patients with intra-arterial, intramural anomalous left coronary artery, it is reasonable for elective repair between the ages of 5 to 10 years, given the risk of sudden death, notably with exertion. For patients with asymptomatic intraseptal anomalous left coronary artery, the risk is exceedingly low, and in the absence of a compelling argument as to why any sort of surgery should be undertaken, I would not recommend surgical repair or exercise restriction. Collaboration between centers is essential. We have the multi-center AOCA registry of the Congenital Heart Surgeon Society, and using this registry and the data from that and the collaboration between them and other centers, I think hopefully in the next several years we are going to have some answers to some of these questions that we currently have. Thank you.
Julie, that was just a fantastic presentation. Thanks so much for that. Very sobering and just a sort of a wonderful way of looking at a perspective of how to assess these particular patients. And as you were sort of going through this and the particular numbers, what struck me, and this is more of a comment than really a question, is just how families can sort of look at these numbers and try and estimate or calculate or make decisions. To a degree, we can't ask families to do that. It is our judgment to make based on the data and work that you've been doing over the past decade in terms of generating this data and this filling this gap in knowledge of understanding what the implications are of each of these different variations. Because from the perspective of a parent, I don't care what the statistic is, it's one patient, one family, and if an event is at increased risk for occurring, then that family may very well say, well, everything else is statistics, quote unquote. But yet we have to be able to make those judgments because of the fact that, doing nothing has a risk, but doing something may have a greater risk in some way. How do you use that language? How do you convey that to families? I'm sure you've had that challenge before.
Yeah, it is a challenging talk with the families. I listen a lot. We do go over the statistics. I talk to them. I tell them to think about it. I like to think of it as a really communication between us and a relationship that we have. I think they need to understand that we don't have all the answers, that we are working on having all the answers, but our first goal is obviously to make sure that their child is safe. We want them to be able to do sports. We want them to be able to live their life in the same manner that they were. I think one of the differences between this congenital heart disease and some of the others is that frequently these patients are found later in childhood, often serendipitously from an echo that was just done. Maybe they had some palpitations or something that was really felt to be non-cardiac, and this is found, and now it's life-altering. Whereas I think sometimes when you have a congenital heart disease that was known in utero, and you've kind of lived with it your whole life, it's different. These families, it's a big change for them. But it's just really having discussions with them, multiple discussions. Usually, unless it's easy, they had ischemia, they had something that's easy. But in these asymptomatic patients, it's really a lot of thinking, a lot of talking on the phone, coming back in person, whatever it is, talking to others. We just try and make the best decision that is right for that family, because what's right for one family may not be right for the other family. And I've had families where they are scared to let their child run to take the school bus. And the impact on the quality of life can be substantial. And in those cases, we have a discussion. If it's necessary to do surgery, this is the risk of surgery. These are the risks. They understand those risks. And then we may go forward with the surgery if it's that limiting to them. But it's a lot of give and take.
Yeah, and it's got to be individualized. And of course,
very much.
It is all about the objective of quality of life. So let me ask you a couple of specific questions that have come up. So to what degree do symptoms play into the decision making for operative versus non-operative management, and in particular for the right coronary arteries?
Yeah, I think, so a lot of patients come to attention because they have a quote unquote symptom, and I don't, mean to make it a small thing, but say they have, chest pain at rest. But they come to the attention of the cardiologist. Maybe they've had it one time with exercise. So then they get the echo, and the echo shows this. So it's incumbent upon us to kind of tease out if the symptom truly is cardiac or really is something musculoskeletal, or say, especially syncope with exercise. I think that for us is our biggest red flag with coronary anomalies, is really syncope or real bad, like pre-syncope, like my first patient I had shown, and really teasing out and understanding, did you faint mid-stride? Did you faint like right when you stopped and it just collapsed? Or was it that, 10 minutes after you exercised, you were sitting down and you stood up fast and got dizzy and passed out? It's a very different history when you hear that, and a different algorithm I would use in someone who had exercise-induced syncope, who had dizziness after sitting for a bit, stood up too fast, versus someone who has it mid-stride. So I think the history is of utmost importance for us to understand what these symptoms are and what we're going to recommend for treatment.
Yeah. So there's the anomaly itself, and then there's the stressor, and often it's the combination of the two. The stressor, most of the time, being exercise here. So does exercise restriction play a role in any of these patients?
Yeah, so that's a really good question. It used to. So it used to be in the guidelines, in the Bethesda guidelines, that when these kids were diagnosed, serendipitously or not, they either, to go back to competitive sports, it was either surgery or you're exercise restricted. You're not doing sports. So it was very difficult. You know, these patients literally who have had no symptoms and they're found, you know, like a screening echo. And now you tell this family, well, you're going to have surgery in order to go back and have your son go play hockey. So after, you know, we've done some research and shown that, you know, significant quality of life decrease with exercise restriction. I think there's a lot of issues I have with exercise restriction, and thankfully those guidelines have changed. First, so when we say exercise restriction, what does that mean? Does that mean we want them to sit on the couch and not even participate in gym class? And this is not good for our long-term cardiovascular health. This is not what we want with exercise restriction. And some people may take it as that. Number two, you exercise restrict these patients from competitive sports, and now you have, let's say, the 15-year-old basketball player, instead of playing basketball with his team in a actually controlled place in the gym where there's actually AEDs, they're off spending their time now in the, you know, at home or in the playground going hard. They go hard when they play together, and something can happen. We definitely have had a few kids who've had events actually off in the playground. And third, like I was alluding to, the quality of life. I mean, when you take away someone's, you know, they've been part of a sports team for 10 years or 8 years, and those are their friends. That's like part of their life. And to tell them that they no longer can do that impacts their quality of life significantly. I will say we have had some some families have really, so one family the kid was playing hockey, and what they did is they put him over to become a goalie. So they've made some little changes that have been really nice, and they feel safer that way. It wasn't even that we suggested that, but they felt safer that, you know what, we wanted to continue. We're going to have him play goalie, and we think that that's it's not as much of the back and forth exercise, and I think that that's great. So for all those reasons, we do not recommend exercise restriction anymore. It's really, they can go play competitive sports, you know, ideally with an AED around, or if you feel strongly, then they should have surgery. So those are kind of the two options.
Yeah, yeah. So Julie, do you think there might be any other therapies to offer besides surgery? So for example, you mentioned if we think the secondary mechanism of the event may very well be an arrhythmia, might, say, drugs like beta blockers or other types of therapies be potential options?
Definitely something that we've talked about doing some sort of a prospective trial with beta blockers, because they're very rarely used, at least in the pediatric population for this. The issue with a prospective clinical trial is the endpoint of ischemia or sudden cardiac events are so rare. I mean, I think the trial would be for anomalous right coronary artery patients. It would take years upon years, right, decades, for us to get a large enough number of patients with the endpoint to be able to tell if there's a significant difference. That being said, in the adults, there have been some literature about patients who have had angina with anomalous right coronary artery, and they've treated them with oral beta blockers. In the short term, about 6 months, they reported that they no longer had angina, very short term. And it has been used in the pediatric population when there are congenital coronary anomalies that do not seem amenable for surgical repair based on the anatomy, but the patient has evidence of ischemia on provocative testing and or symptoms, and beta blockade has been used and seems to be somewhat successful. So, you know, there may be a role for it in that, and there may be a role for it in these other patients, but I can't say, and we just don't normally use it, but it is definitely something that we've thought about and is something to think about for the future.
Yeah, great. Let me shift gears now and ask you a little bit about the role of exercise and activity in general in your life. So I know I've, quote, run into you at different times, either on a particular trail somewhere or most of the time actually at the Starbucks or a coffee place after you've had a run, and maybe I've done a little bit of exercise, but I know that running and exercise and activity play an important role in your life. How did that develop? Was that something that you did as a young child? Was that something that occurred later in life? How do you incorporate that into your busy life today?
Yeah, no, it's a good question. I was a gymnast growing up, and then And then in college got into step aerobics, so that'll show you my age. And then went to, in medical school, just went to the gym. And then in residency, my best friend was a runner. And I would watch her go out and run, and I was like, maybe I should just try. So started running in Portland, Oregon, which is actually a very big mecca for running. Started running there and literally haven't stopped except when I've been injured. For me, and I think for a lot of us who run or do other sort of exercise, it is our alone time, it's our me time, it's our de-stressor. And it just means waking up a little earlier than you normally would, and you get it out of the way. And I'll tell you, even if you're really tired and you come back from a run or you come back from whatever you did, you always feel better. You will never regret coming back from a run. You will regret that you overslept.
That's it. That's
right?
a great. That's a great aphorism. Actually, I like that a lot. Yeah. Now you just don't run. You run. You've done marathons, right?
Yeah.
So do you want to show us a little bit about some of the things that you've been doing and what you're interested in?
Sure. So I wanted to start out showing this. This is a video of Des Linden, for those of you who are not runners. She's a professional runner who is our idol. A lot of our friends, she's our idol. She was the first U.S. woman to win the Boston Marathon in 2018 since 1985. What was so significant about this, you can kind of get a sense, the weather was brutal, about 34, 35 degrees. 30+ mile an hour headwind the entire way. So the Boston Marathon is a one-way course. So if you have a headwind, it's brutal. If you have a tailwind, it's amazing. There was also driving rain. You can see it's wet there. It's not quite as bad as in some places where it was ankle deep. It was horrible. Des slowed early on to help her fellow elite runner, Shalane Flanagan, who won the New York City Marathon in 2017, to help her get back in the pack after she had a porta-pot stop. Des didn't feel good. She was like, I think I might drop out. But she didn't. She persevered. She kept going. She broke away from the pack around mile 21 for a solo win for the 2018 Boston Marathon. It was just so awe-inspiring, just an amazing success for her and for U.S. running. Her grit is really significant. And I love this saying from her, and I think about it often. She says, every day I make the choice to show up and see what I've got and try to be better. Keep showing up. So just kind of what I said is you'll never regret a run or a workout. You just got to keep showing up. So I want to quickly talk about reasons to get moving and why we should exercise. I think especially during this COVID-19 pandemic, I just think it's so important for many reasons. So it helps our immune systems fight off illness. So it helps to fight off getting COVID. It helps their mental state and our stress relief, and many of us are feeling probably more stressed during this time. It keeps our heart and muscle strong. So as cardiologists, we want to have, tell our patients too, you want to have really strong muscles, including our heart, which is a muscle. Certainly, exercising keeps us ready for future races, future events. Importantly, it's a nice break from being at home. So those of us who have been at home more, maybe now with online schooling or just during the pandemic at home, it's just a nice break to get out a bit, enjoy the outside, enjoy nature. Studies have shown it also helps prolong your life, so another great reason. And it's a great time to be with friends. Now, maybe 6 feet distance with masks, but you can still gossip and get your heart rate up out with your friends. So how can you motivate to kind of get moving? And I've used these many times in my life. Make a plan and write it down. Plan ahead for the upcoming week. So if you know you're going to be on service, take that as a down week. Take that as a time to do less, maybe less miles, less intense activity, just knowing you're probably going to be more tired and you don't want to risk injury. But plan it out. It's important. You want to start small. Don't sign up for a marathon with 6 weeks to go when you haven't run in 20 years. You will get injured. And I say this from experience from someone in my family who did that. You want to set short and long-term goals. So something like, I want to do this 5K in 2 months. I'm going to sign up for get that couch to 5K program. It's going to mean 30 minutes a day or whatever it is for the next 8 weeks. And that's a nice short-term goal. And then maybe in the long term, you say, I want to next year I want to run a marathon or a half marathon, or I want to do that 100 miles bike ride, or whatever it is. It's really nice to have that short-term goal so you kind of see some results in the short term with that long-term goal as just something to have in the future to look forward to. Another really important thing is dedicating a certain amount of time and time of day. So you know yourself. You know if you are a morning or a night person. So if you're a morning person, just get up a little earlier. It's hard in the dark, but just do it. You'll be super happy. And if you're a nighttime person, I think it's a little harder, especially if you have kids, to come home. But hey, maybe just go straight. Don't come home first. Go do your exercise and then come home. And then knowing that amount of time you're going to do, be it 30 minutes, 45 minutes, whatever it is. And then this last one, I think is probably one of the most important things, is really practicing gratitude and positive thinking. Any of you who have been injured or unable to exercise for a time know how important this is. I did this when I was injured a couple years ago and was stuck aqua jogging, and every day I said 10 gratitudes as to, why this isn't that big of a deal. There are many other things I can be grateful for. And so I think just remembering, say yourself, I'm lucky I get to exercise today. And I'm so grateful to have a body that can run or move or walk or ride a bike or whatever it is, because we all know people, our patients, our family members who aren't able to do that. And I think just kind of flipping it from saying, oh, I have to go out today, instead of saying, I'm really fortunate to be able to go out today. So I'm going to sum it up now, how we're going to motivate to move. You're going to start out taking baby steps. And it's going to feel hard at first. Whatever you embark on is going to feel hard. And you may want to lay down and rest, and you may be doubled over a little bit with, out of breath, and that's okay. Because you're going to tell yourself, you're going to take that positive thinking and tell yourself that you can do it and you can finish what you started. Because I'll guarantee you, when you're done, you're going to be excited to do it again the next day. So if you want to make change, the time is now. And I think you want to ask yourself, is this just one day you're going to do something? Or is this day one of doing something new? Are you going to move forward now? And then you can do a dance and just say, you got this, you can do it. Thank you very much.
Julie, that was awesome. Your talk was fantastic. And thank you so much for that wonderful advice. Thanks so much.
Thank you.
And thank you all for your attention and for listening to this fantastic talk and life lessons and life advice. We are very much interested in your feedback, and we'd love to hear questions concerning our content that you've heard, as well as suggestions for additional topics that would be of interest to have reviewed in depth and discussed. In order to communicate with us, we have a dedicated email address. It's chophearttalks@email.chop.edu. We'd appreciate hearing from you. We'd love to hear your ideas and suggestions. Thanks so much for your attention.